Hi, my name is Karin, and I will be presenting Crohn's disease with my group mates Brandon Chu and Neydin Lazo. Crohn's disease is essentially a relapsing systematic inflammatory disease that mainly affects the gastrointestinal tract. Crohn's disease typically presents and causes lesions that extend from the mouth to the anus and can result in extraintestinal complications. Crohn's disease also typically presents with fever, abdominal pain, unusual weight loss, fatigue, and bowel obstruction with diarrhea containing blood and or mucus. We chose this disease because it presents parallels with Duchenne muscular dystrophy in regards to causes, diagnoses, mechanisms, and treatments. In the US, the prevalence of Crohn's disease is estimated at about 58 per 100,000 children and approximately 119 to 141 per 100,000 adults. However, the prevalence rate is increasing for both groups. Additionally, white individuals and individuals with higher education levels are correlated with increased prevalence. The typical age range for when Crohn's disease is diagnosed is typically around the age of 20 to 40 years, although new cases still can occur later in life. The, the annual economic burden of Crohn's disease to US healthcare is estimated to be about $6.3 billion annually. Researchers have found that there are several factors that may contribute to the cause of Crohn's disease. These factors include genetic susceptibility, environmental factors, and altered microbiota. However, the specific cause of Crohn's disease still remains unknown. Genetic susceptibility plays an important role in the development of Crohn's disease. The NOD2 or CARD15 gene is selectively associated with Crohn's disease. More specifically, researchers have found that the homozygosity for the NOD2 gene increases the risk for developing Crohn's disease by 20 to 40-fold. However, only 13.1% of the disease heritability is due to genetic factors, thus epigenetic and genetic environmental factors play an important role for the risk of Crohn's disease. Environmental factors play an important role in the development of Crohn's disease. Environmental factors that have been associated with the increased risk for developing Crohn's disease include oral contraceptive usage, smoking, antibiotics, or exposure to urban environments, and regular use of anti-inflammatory drugs. However, environmental factors that are associated with a decreased risk for developing Crohn's disease include exposure to farm animals and pets, sharing a bedroom, high fiber intake, physical activity, fruit consumption, and having more than 2 siblings. A feature of Crohn's disease includes gut dysbiosis, which is most likely caused by diet, which is affecting the intestinal microbiota. More specifically, the cause for a disruption or alteration of the host-gut microbiota relationship is due to the change from a low-fat, high-fiber diet to the consumption of foods that typically contain food additives, such as processed foods, low-fiber foods that contain a lot of fat. The reduction of dietary fiber intake and frequent dietary changes between high-fiber and low-fiber foods facilitate a reduced gut microbiota diversity, which is associated with the development of Crohn's disease. Researchers have found that increased adherence to a Mediterranean diet is associated with a significantly lower risk of Crohn's disease. Overall, there are many similarities and differences between the causes for Crohn's disease and DMD. Genetic susceptibility plays an important role in both Crohn's disease and DMD. In both diseases, there is a specific gene that is selectively associated with the disease. Crohn's disease is associated with NOD2, and DMD is associated with dystrophin. The diseases may arise from mutations within their corresponding genes. However, for Crohn's disease, genetic susceptibility alone does not facilitate the development of the disease, but rather a combination of environmental factors, altered microbiota, and genetics play an important role in the risk for developing Crohn's disease. The initial diagnostic process for Crohn's disease of a mildly symptomatic patient involves the evaluation of patient's family history, undergoing a physical examination, and proceeding with basic laboratory tests. The physical examination should include an abdominal examination that checks for tenderness, masses, and/or desiccation. However, patients may also present with extraintestinal findings before the onset of any gastrointestinal symptoms, which may include symptoms in the eyes, joints, hematologic system, and skin. Additionally, vitals such as blood pressure, pulse, respiratory rate, body weight, and temperature should be measured as well. The physical examination would help determine if the patient's condition is unstable, which may require them to need immediate care. Additionally, the physical examination should include an anorectal examination, which looks for any extraintestinal complications. It is also recommended to conduct a pelvic examination as fistulas, fissures, and abscesses are common developments with Crohn's disease. The laboratory testing serves multiple purposes for evaluation, which includes diagnosis, monitoring the activity of the disease, and tracking any adverse effects and the effectiveness of medications. The recommended laboratory tests include a complete metabolic panel, complete blood count, C-reactive protein level, erythrocyte sedimentation level, and pregnancy test. Measuring the blood count is important because anemia is commonly correlated with Crohn's disease. Additionally, measuring the C-reactive protein, stool lactoferrin, and fecal calprotectin can help in the process of assessing the disease progression, which could limit the need for an invasive endoscopy with disease management. Furthermore, it is recommended to complete stool studies to eliminate possibilities of other parasites or ova that may be present. However, if the patient appears to be having severe symptoms, then the physical examination and computed tomography scan, ultrasonography, and magnetic resonance imaging will be the initial diagnostic testing process. These techniques not only are useful for making the initial diagnosis, but they help identify complications and monitor the disease activity. Additionally, these techniques can be used for identifying the extraluminal pathology as well as examine the gastrointestinal tract that may not be accessible through endoscopic procedures. Depending on how well the patient can tolerate contrast load, the CT and magnetic resonance enterography are recommended over standard CT and MRI protocols. However, while these techniques provide the most consistent results, they do admit radiation exposure, which may have negative consequences on the patient. Alternatively, magnetic resonance studies do not admit any radiation exposure, although this technique is expensive, likely will have limited availability, and may be more difficult for the patients to tolerate. As for ultrasonography, this technique is more readily available and requires no radiation exposure. However, ultrasonography is very operator dependent and may be limited to body physique or body build of the individual. Overall, choosing which technique or modality to use is dependent on the patient's pregnancy status, local expertise, availability, current local conditions, and age. If the initial diagnostic process reveals any indications that the patient may have Crohn's disease, then the next diagnostic testing is typically the ileocolonoscopy with biopsy for confirmation, or the esophagogastroduodenoscopy for children. This endoscopic procedure would allow the direct visualization and access of the bowel lumen. This direct visualization then allows for the identification of lesions characteristic to Crohn's disease for monitoring of the therapy's failure or success, and for the screening of colorectal cancer. A subsequent cross-sectional imaging would be performed to identify the full extent of the disease if it was or was not visualized by the endoscopy, which is important for developing a treatment plan. If both the cross-sectional imaging and ileocolonoscopy are negative, but there is still high concern for Crohn's disease being present, the next diagnostic process would be a capsule endoscopy. If the capsule endoscopy results read negative for Crohn's disease, then Crohn's disease is likely not present and is absent. However, if the results are positive, then it is likely that Crohn's disease is present. Overall, there are similarities and differences between the diagnostic process for Crohn's disease and DMD. The diagnostic process for both Crohn's disease and DMD typically start with family history, physical examinations, and laboratories. However, differences between these two diseases and the diagnostic process include that the laboratories for Crohn's disease typically involve the complete metabolic panels, complete blood counts, C-reactive protein levels, and other more related laboratory results that involve fecal matter. For DMD, the laboratories include CK values, and if the values are markedly higher than the normal range, then the diagnostic process continues into biopsies or testing for mutations of the dystrophin gene. Additionally, DMD diagnostic processing typically involves H&E staining procedures, immunoblots, immunofluorescence, etc. Whereas for Crohn's disease, the invasive protocols typically are looking for more visible lesions using ileocolonoscopy and biopsies. Additionally, both diagnostic processes also conduct physical examinations. However, for DMD, the physical examinations conducted typically involve testing for muscle strength or functional impairments, whereas Crohn's disease physical examinations are conducted to determine if there are any symptomatic abdominal abnormalities.
Pathology. Now that we've covered the factors that predispose an individual to Crohn's disease, genetics, environment, and gut microbiota, we can begin to see how each piece affects what might be otherwise a healthy gastrointestinal or GI tract, and how Crohn's develops from there. Healthy mucosa. Here is a cartoon of a transverse cross-section of the small intestine, specifically the innermost layer called the mucosa. There are many protective components that prevent the pathogens from leaking out. Before any of the patient's defenses are a swath of harmless bacteria that pathogens must compete with for resources. First of the host defenses is a layer of mucus-like mucin, which is a physical barrier that prevents food particles, enzymes, and gut bacteria from approaching the epithelia. Opportunistic or any other bacteria that find themselves too far into the mucin are met with antimicrobial peptides and antibody dimers. These work to discourage, disable, and destroy bacteria that get too close to the otherwise vulnerable layer of epithelia. The next layer of defense is the epithelial cells themselves. Linked together with tight junctions, not even water can pass through without the help from epithelial cells. The last layer of defense is a complex system of immune cells just behind the epithelia and the lamina propria. These cells identify any bacteria that make it through and respond appropriately. Commensal bacteria, or bacteria that are largely harmless, are responded to without much fuss. Opportunistic or pathogenic bacteria are met with a much more intense response, recruiting armies of cytotoxic and phagocytosing immune cells to wipe out the threat before they can cause any severe damage. Pathogenesis initiates when breakdowns occur in the structure and function of the mucosa. The immune system tips in favor of inflammatory responses, and the microbiome composition skews toward harmful bacteria. Barrier dysfunction. The protective mucin layer can thin, or be even worn down completely when mutations occur in MUC1, MUC2, MUC19, and PTGER4 genes. The goblet cells that normally secrete mucin become defective without functioning copies of these cells, and the bacteria aren't impeded by the mucin in the approaching epithelium. The Paneth cells that secrete granules of antimicrobial peptides and antibodies can lose their protective power when mutations in ATG16L, XBP1, and Node2 occur. All told, the structures and chemical agents that prevent bacteria from straying too close to the epithelium can easily wear thin. Finally, the epithelium itself can be weakened by mutations in genes encoding claudins, the primary proteins used in tight junctions. Without these tight junctions, bacteria and food particles can slip between the epithelial cells and into the lamina propria. Immune imbalance. The normally well-balanced immune responses can be affected by mutations to TLR2 and TLR4, which drastically increase the ratio of inflammatory immune cells to tolerant or tolerogenic immune cells. Node2 also causes tolerogenic cells that are left, such as Treg, to be less able to suppress immune responses. The result is that the lamina propria is flush with Th1 and Th17 cells itching to launch an inflammatory response for which there are no brakes. Dysmicrobiosis. The environmental and microbiome influences combine in the diversity in the microbiome, where a normal individual has a healthy level of Bacteroides and Firmicutes bacteria, known for being benign and generally able to make sure pathogenic bacteria can't easily gain a foothold. A person with Crohn's often has far fewer of these commensal bacteria. Instead, there are high levels of gamma proteobacteria and actinobacteria, which are often opportunistic pathogens and are more likely to try to infiltrate the intestinal walls and escape to wreak havoc. With all these factors in place, we can see how pathogenesis starts. A pathogenic E. coli finds an unprotected gap in the epithelium, its path unimpeded by mucus, peptides, or antibodies. It slips into the lamina propria, where it and the toxins it produces are quickly detected and eliminated by an inflammatory immune response. But the immune response, with its cytotoxic agents like IFN gamma, TNF alpha, IL-17, and IL-22, are excessively secreted into the surrounding tissue. These agents are so powerful that they kill the offending bacteria and heavily damage all the surrounding epithelium as well. This leaves new area of the mucosa exposed to further invasions. As pathogenic and opportunistic bacteria infiltrate the newly compromised intestinal walls, the overreacting inflammatory response follows, and the cycle repeats. As the epithelia are damaged, the GI's ability to absorb nutrients and water from its contents become compromised, leading to nutritional deficiencies and diarrhea. Accumulation of GI damage can lead to ulcers or open sores, strictures, where stem cells attempting to repair the damage have regenerated scar tissue instead, abscesses or fluid-filled cavities carved into the surrounding tissue, and fistula, where the damage is so extensive that holes are punched into adjacent sections of the GI tract, adjacent non-GI organs, or even to the skin. Extraintestinal symptoms, which may manifest before or after diagnosis, include redness or pain in the eyes or changes in vision, swollen joints or joint pain, skin rashes and tenderness, and osteoporosis. These symptoms can go into remission or periods of minimal or no symptoms and can flare up again. With proper treatment, patients can experience several years of mostly symptom-free living between flare-ups. Many of the components of pathology and symptoms may seem familiar. The instigation of damage to the mucosa by structural defects in the tight junctions mirrors that of the defects in dystrophin that compromise the structure of myofiber membranes. Another parallel is the role an inappropriate immune response plays in exacerbating the damage by recruiting too many inflammatory immune cells that inadvertently damage surrounding tissues. Nearby epithelia in the case of Crohn's disease, and nearby myofibers in the case of DMD. Issues with the way stem cells differentiate improperly to further disease runs in both diseases as well, In the case of DMD, satellite cells start to differentiate into fibroblasts instead of myocytes, leading to the replacement of muscle with connective tissue and loss of flexibility in those muscles. This is the same process as Crohn's disease, where mesenchymal stem cells produce scar tissue, forming strictures and blockages in the GI tract where nutrient or water-absorbing epithelium should be. As a result, both diseases are also cyclical in the way disease progression often accelerates if left untreated.
Treatments for Crohn's disease. Treatment of Crohn's disease aims to achieve sustained clinical and endoscopic remission, mucosal healing in this case, in addition to interrupt the naturally progressive destructive disease course that culminates in intestinal failure and associated complications. But how is this treatment assessed? The choice of the initial drug from an increasingly expanded matrix of medication is directed by the phenotype of the patient, disease activity, comorbidities, and other individual characteristics of the drug and the patient. In most cases, a fast-acting short-term use agent is used to achieve rapid symptom relief and disease control. One of the treatments that can be used in Crohn's disease is the use of mesenchymal stem cells. They exist in almost all tissues and are believed to reduce exacerbated inflammation due to their intrinsic immunomodulatory properties. There are three important steps among these immunomodulatory properties. The first one is migration to sites of active inflammation or tissue injury, followed by of anti-inflammatory molecules like IL-10, HGF, TGF-beta1, and IDO. And lastly, paracrine signaling to nearby cells to maintain the local anti-inflammatory environment. Thus, by influencing cytokine secretion profiles, mesenchymal stem cells can modulate the function of various immune cell types, including lymphocytes, dendritic cells, and macrophages. Significant and specific to Crohn's disease is the ability of mesenchymal stem cells to upregulate a CD4+ T cell subset to regulatory T cells. These are also known as TRAC cells, a cell type known to be deficient in Crohn's disease. It has been well established that the depletion of TRAC cells and imbalance of TRAC to T effector cells play a key role in the pathogenesis of Crohn's disease. Therefore, mesenchymal stem cells' ability to upregulate TRAC cells, migrate to sites of inflammation, and dampen immune responses underscores the escalated interest in using mesenchymal stem cells to treat Crohn's disease. For example, preclinical studies have shown an immunomodulatory effect of mesenchymal stem cells that is expressed by the inhibition of T cell function, proliferation, as well as increase in regulatory T cells. In addition, while performing our extensive research, we found that it has been reported that mesenchymal stem cells isolated from Crohn's disease patients are functionally analogous to those of healthy individuals. The above-mentioned effect is mediated by the induction of endoleamine 2,3 dioxygenase. However, mesenchymal stem cells administration is reported to be effective in inducing fistula healing, yet the mechanism promoting fistula healing is yet to be fully explored. We will now take a look at the mechanism of mesenchymal stem cells therapy. It is important to note that this procedure is considered as an alternative to standard medical therapy and supplementary surgical procedures. The major mechanism for mesenchymal stem cells therapy is the paracrine function. Paracrine, as mentioned before, secretes a variety of soluble factors to exert immunomodulatory, angiogenic, anti-apoptic, and antioxidative effects. Thus, cell-to-cell contact enables mesenchymal stem cells to modulate their immunosuppressive effect and promote cell viability. In this case, immune cells and endothelial cells interaction. In addition, mesenchymal stem cells can transfer mitochondria to injured cells via tunneling nanotubes, as we can see in the diagram. Lastly, they can reduce inflammation and increase cell proliferation during tissue repair via releasing exosomes, which are extracellular vesicles that contain reparative peptides and proteins, mRNA, and microRNA. So how does mesenchymal stem cells relate to DMD? The use of stem cells therapy has also been studied in Duchenne muscular dystrophy. It is considered to be one of the most promising methods for treating muscular dystrophies. Stem cells are defined by certain features and foremost, an ability for long-term self-renewal and the capacity to differentiate into multiple cell lineage. Mesenchymal stem cells impose an additional anti-inflammatory and peregrine effect on differentiation and tissue regeneration via cytokine pathway, and have an anti-apoptotic features in DMD. These genetically determined pluripotent cells may be easily isolated from bone marrow because they have membrane proteins, compared with pluripotent or induced pluripotent stem cells. Mesenchymal stem cells have a greater biosafety profile and lower risk of tumorigenicity, and perhaps that is why a lot of therapies have made it to clinical trial stage. Therefore, the ability of mesenchymal stem cells to differentiate into various injured tissue, including muscle, as well as the ability to complement dystrophin deficiency, makes them an attractive therapeutic candidate for DMD. Another treatment for Crohn's disease is the use of corticosteroids. Corticosteroids lower the activity of your immune system and limit the inflammation in the digestive tract. They're used as short-term treatments for Crohn's disease and ulcerative colitis flares because they reduce inflammation quickly, sometimes within a few days to a few months. They can be administered oral, injected, topical, and rectal. Within the corticosteroids family is methotrexate and prednisone. These are both effective and well-tolerated treatments for patients with chronically active Crohn's disease. For example, in a double-blind, placebo-controlled, multi-center study, weekly injections of methotrexate in patients who had chronically active Crohn's disease, despite a minimum of 3 months of prednisone therapy, was performed. At the time of randomization, the patients had moderately active disease despite of receiving 20 milligrams of prednisone each day. After treatment with methotrexate, significantly more patients were able to discontinue prednisone use than were patients receiving placebo. Because long-term prednisone therapy is associated with a variety of harmful consequences, methotrexate represents an alternative treatment for patients who do not tolerate prednisone or in whom symptoms of Crohn's disease persist despite a moderately high dose of prednisone. Although these patients received less prednisone, the patients who received methotrexate had improvement regarding disease activity and were more likely to enter clinical remission. Can methotrexate be useful in Crohn's disease? Well, this experimental data leads us to ask, methotrexate can be useful in Crohn's disease. Next, we can observe experimental data obtained from the above-mentioned study. In a group of patients with chronically active Crohn's disease, methotrexate was more effective than placebo in improving symptoms and reducing requirements for prednisone. In this study, the same proportion of patients in 2 groups was withdrawn from treatment prematurely. Most of them withdrawn because it was more effective in methotrexate than placebo. After 16 weeks of this study, the proportion of patients who had discontinued prednisone therapy and remained in remission was higher in the methotrexate group than in the placebo group. 39% compared to 19%. In the high prednisone stratum, this outcome occurred in 39% as compared to 10%. In contrast, 14 of 35 patients receiving methotrexate in the low prednisone stratum, 40%, had primary outcome as compared to 35% receiving placebo. Corticosteroids produce their effect on immune cells by activating corticosteroid receptors to regulate the expression of certain target genes. Corticosteroid molecules are transported by steroid-binding proteins. Dissociated corticosteroid molecules cross the cell membrane freely. Once inside the cytoplasm, they bind to the receptors. The corticosteroid receptor complexes translocate into the nucleus, where they bind to the glucocorticoid response elements in the promoter region of steroid-responsive target genes, either promoting or suppressing the transcription of a particular gene. Corticosteroids may also decrease the synthesis of a particular protein post-transcriptionally by affecting the degradation of messenger RNA and translation of mRNA via enhanced synthesis of specific ribonucleases. In the case of protein A, corticosteroids promote the transcription of the gene encoding protein A, enabling the synthesis of a new protein A. In the case of protein B, corticosteroids inhibit the transcription of gene B and may further decrease the synthesis of protein B by increasing the degradation of its mRNA, inhibiting the translation of its mRNA. Altered cellular function results from the combination of increased production of certain proteins and decreased production of others. Despite their wide use, the exact mechanism of action of corticosteroids is still elusive. As mentioned before, Crohn's disease resembles Duchenne muscular dystrophy in many ways. The use of corticosteroids also results beneficial in DMD. Since DMD includes in muscle wasting and loss of walking lead to wheelchair dependence and eventually death, the use of corticosteroids improves muscle strength and function in the short term, and strength up to 2 years, including respiratory muscle strength and function for 6 months. Long-term therapy delays the loss of ambulation by several years, reduces the need of vertebral surgery, improves cardiopulmonary function, postpones non-invasive ventilation, and generally improves life expectancy and quality. For example, some of the corticosteroids that have shown improvement in DMD are deflazacort and prednisone. They are not a cure, but they both significantly slow the progression of muscle weakness, disease progress, and functional loss. Their usage in DMD may prolong ambulation and upper limb function with similar potentials. Both steroids also improve pulmonary functions in addition to delaying the need for spinal intervention with similar therapeutic profiles. Although side effects may occur, they can be used depending on each patient.
And now a brief interview of a personal experience of Crohn's disease and some parallels in living with chronic disease between DMD and Crohn's disease, including dietary restrictions and regular checkups with multidisciplinary teams of physicians. So I happen to have a friend who has Crohn's disease who has kindly volunteered their time to talk about their experience with Crohn's disease. Hello, how are you today?
Hello, I'm doing well today. How are you?
I'm doing good. Thanks for coming. So I'd like to start off with asking, how did Crohn's disease affect your life leading up to your diagnosis?
Okay. So leading up to my diagnosis, I was first diagnosed when I was 14 years old in November of that year. And I think I first noticed any symptoms in around June of the same year. So it's a reasonably quick process, about 6 months from my first symptoms to my diagnosis. For the first several months, they were very minor symptoms. I was passing some mucus in my stool, and that was about it until around September or October or so, probably closer to September. So yeah, until around September, there was really not much going on. I was in contact with a gastroenterologist, and we were sort of just watching it to see what would happen if it would go away. We weren't really planning to take any action at that point. Yes. But then at some point in the fall of my freshman year of high school, I started passing blood in my stool as well. And I also lost a lot of weight. So this wasn't good. I think at a similar time, we decided to go ahead and do a colonoscopy, which I was actually initially diagnosed with ulcerative colitis because my Crohn's is primarily in my colon. I was later re-diagnosed with Crohn's the next year when we found inflammation in other areas. But I guess for a while, it didn't have much of an impact, but towards the very end, I was in the hospital for about 2 weeks. And I was like very fatigued, did not have much energy during this time. I'd lost a lot of weight. I was very anemic as well. I assume because of a combination of passing blood and just in general. Yeah, so I was really tired, trying to go to class, like could not wake up in time to make it to school, was having a hard time making it through the day. And I was in a decent amount of pain as well beforehand. I think that's all I have for this one.
Okay, thank you for sharing. And Crohn's disease has flare-ups and remission. Can you tell us about your experience during flare-ups and periods of remission, if you've had any?
Yeah, of course. So after my initial diagnosis, do you want to hear about medication at all? I don't know.
Yeah, go for it.
Okay. So after my initial diagnosis, I started, I was briefly on mesalamine, but that didn't do much for me. So I started on infliximab pretty quickly, I think while I was still in the hospital. Oh, and I was also on prednisone for a while. My goodness, it's so long ago. But I think by around maybe February, March of that year, I started to do a bit better. I'm not sure I was in full remission at that point, but definitely trending that direction by like spring, summer of the year after the year immediately following my diagnosis. And so that was okay. It was, I guess, a little bit rough figuring out medication initially. There's definitely some things that were tried, some messing with dosage, some prednisone side effects, not too many infliximab side effects. But that was, I guess, the in-between a flare and remission. Then I'll talk more about remission going forward, but then I had another flare the next fall, which is why I had, when I had the second colonoscopy where I was re-diagnosed with Crohn's. And I guess this flare wasn't as bad as my initial flare that led to my diagnosis, partially because we already knew like what was causing it. And so I was able to get on prednisone again and end it fairly quickly. So it was still definitely a time when I was feeling very fatigued, passing blood Again, not as much as the previous time. Just generally not very fun. I think appetite, mood, just kind of all over the place. Generally not feeling good, I guess. But then I guess after this second flare, which I sometimes say it was like a mini flare, just because it was definitely still a flare still, but we were able to get it under control fairly quickly. Then a while later, I was able to get into remission, and I have been in remission since then. So I think that's since around like spring of my sophomore year of high school, or about year and a half after my initial diagnosis, and I've stayed in remission since. And in general, I think I'm doing pretty well. I do have occasional symptoms, like occasional abdominal pain, or if I eat certain foods, sometimes my stomach will get a bit upset. I guess I'll have some abdominal pain in response to certain foods occasionally, like trigger foods. But in general, I do pretty well. My energy tends to be good. No blood in my stool in quite a while. Occasional mucus, but that doesn't say it's not persistent, which is nice. Yeah, my medication's also gotten more stable. Yeah, we've been still occasional adjustments to like dosage or frequency, but I think the things that were causing prednisone was causing me the most side effects. That's not like one most people stay on long term, so I've been off that for quite a while. I don't experience. There's definitely a couple still that side effects I'm experiencing, but for the most part, it's been going pretty well.
I'm glad to
hear. I'm missing something. I don't know.
I'm glad to hear most of your most severe symptoms have subsided and have stayed in remission for a while. As the last question, is there anything that having Crohn's, either during remission or during a flare-up, has prevented you from doing or changed in your day-to-day life, besides what you've already covered?
I guess I've sort of hinted at it already, but I definitely am a bit more cautious as I'm eating to kind of see how things are making me feel, or maybe avoiding certain foods that tend to lead to pain. I have very regular medical appointments for my infliximab infusions. That's definitely can be disruptive for day-to-day life because it's like a several-hour affair between driving there, getting the infusion, and driving back to wherever I was. I'm in college right now, but I still usually come back to my hometown for my infusions because we didn't want to change locations just yet. What else? Oh, occasionally my gastroenterologist is concerned about absorption of different things. Like I know I've taken iron supplements periodically, of vitamin D. There's been a couple others that have been like temporarily a bit low, and so we deal with that. And occasionally if something like if my iron goes down a little bit, maybe I'll be feeling a bit more tired because so I'll get like slightly anemic. But usually not. It usually doesn't like mess up my whole day or anything.
Okay, that was very enlightening. Thank you.
Overall, Crohn's disease and DMD are parallel to each other in regard to causes, diagnosis, mechanisms, and treatments. Genetic susceptibility in both diseases is significant, and they both have a specific gene that is selectively associated with it. NOD2 in Crohn's disease and dystrophin in Duchenne muscular dystrophy. Both diseases are assessed by physical examination, laboratory tests, and family history. Both diseases progress as damage occurs due to a structural failing, followed by over-inflammatory responses that incur more damage and scarring, resulting in a cycle of exacerbation. Since both diseases present similarities and affect a significant number of individuals around the world, Treatments can be associated and evaluated to determine their effectiveness. In this project, we performed broad research about Crohn's disease and how it related to Duchenne muscular dystrophy. We analyzed clinical trials, experimental data, and research articles to be able to make a clear connection and understanding of Crohn's disease and DMD. We mainly found and focused on the use of mesenchymal stem cells and corticosteroids that showed they can be beneficial for Crohn's disease and DMD treatment. However, there is still further research to be done to evaluate the efficacy, side effects, further elucidation of mechanisms, safety, and approach in humans.